Thank you very much, Ben. And thank you, all of you all. I was reflecting on my drive down here this morning that I feel like the Maryland Women's Health Coalition and I have sort of grown up together because I still remember clear as day, and I have a bad memory, so that says something, sitting in my, at that time, pretty new office in the governor's office, like trying to get my bearings and figure out what the heck this was all about. And a group of women came to visit me. And my memory is so bad, I don't have a clear recollection of everyone who was in that meeting, but I know Lenny was one of them. And we, I think, have tried to figure out what all this was, what this was all about and how to move it forward as a state together. And it's been quite a journey, and we're not there yet. But I really do thank the coalition. It's been an incredibly important voice and actor from the very beginning when we were first contemplating that first piece of legislation. So thank you all. I also want to thank Shannon. As you'll see as we go through, the partnership between the exchange and Medicaid is about as critical as it gets. And it's been a key to our success, I think, that we've had that kind of partnership. So I really appreciate that. So now if I can figure out the technology, I'm going to launch right in. Oh, there we go. So first, the retrospective. How did we do last time around? As you all probably know these statistics already, if you get our mailings, 123,000 plus in qualified health plans and over 575,000 altogether in Medicaid. That's had a real impact. You know, we're not there yet, but we have, in fact, cut the uninsured rate. We don't have great data on this yet in terms of recent data, but the first year, we now are beginning to get some good analysis. You can see, according to the latest statistics from the US Census, we have, in the first year, brought it down to about 7.9%. And then, again, this I think probably, you know, we'll have to compare other numbers as they come out, but the online 24/7 Wall Street publication estimated that in the second year we brought it down to just under 5%. So, you know, I'm not sure those numbers are exact, but even if they're close, that's quite an achievement. We are also trying to get better data. Not just so we can sort of be happy about, you know, the extent to which we've dropped the rate of uninsured, but so that we can figure out where people are left who are uninsured. And as we, need to work with fewer and diminishing resources as time goes on, we need to get more and more targeted about how we reach those people. So we've been working with SHADEC to try to get a better sense of where the QHP eligible and Medicaid eligible people in Maryland are and how to reach them. So we've started to try to map this out some. As you can see, here is a map showing you sort of where our enrollments have been. And then, you know, the correlation there is who's left and where are they. So as I said, we're trying to get more targeted in figuring out where people are and then planning our outreach accordingly. So they've even been able to get down to this level of, I think PUMA is I forget what it calls for, but I mean what it stands for, but it's a small area, smaller than a zip code, which is the level of granularity that we're trying to get to in terms of where people are and who's left. The impact of financial assistance has been huge and will continue to be, I think, not only for the people receiving the tax credit and enabling them to afford their health insurance coverage, but just, you know, bringing this kind of financial assistance into the state and, you know, spreading it around in the way that happens when people are able to access health services. I think it's a win-win for everybody. So we've been able to tally up those numbers, and over $140 million in tax credits, with the average household receiving over $2,000 a year. So very good news there. This is our bragging slide, or braggadocious, as Donald Trump would say. We really are proud of, after that first year when you all helped us sort of struggle through the problems with the website, we've been able to make things a whole lot easier, and we're obviously pleased with that. We do have some data to show that last year, overall things were pretty good. There was a pretty high level of satisfaction on the part of consumers using the website. Appreciation for the tools that we do have there. But, as with everything, we have room to improve and to get better, and we are committed to doing that, obviously. We still, people still do, I think we could, we could improve the comprehensibility and sort of consumer friendliness of the website for the next decade, and you'd still have people who need and want assistance, whether it's on the phone assistance or in-person assistance. And so we really need to be cognizant of that in planning our outreach efforts going forward and our consumer assistance methodologies. We have challenges in that regard, as you all know. Resource-based to a large extent. We as you know, have struggled with having enough resources to put enough, people on the phones in the call center. That's what it really comes down to. We have worked hard and are continuing to work hard to, gain more efficiencies in the way that the call center handles calls, do more triaging, get experts in various areas so that, we can reduce average handle times because the agents are more knowledgeable about whatever the particular problem is that the consumer is calling in for. But, that's really around the edges. At the end of the day, you need people on the phones to match the volume, and the volume has been big. So we're continuing to work on that in partnership with DHMH and DHR, and we're hoping to make progress in that regard this time around. We in-person assistance, again, our Connector Entity program has been so incredibly valuable, continues to be. We want to continue to support that. As you know, we put out an RFI earlier this fall to try to get feedback from everybody as to, as we move into the fourth year of the program, are there some adjustments we should make in the way that it's designed, particularly in light of diminishing, funds with the federal funds drying up and reliance now on state resources. So we're sort of collating those responses, and we'll have a better sense, in the coming weeks as to how to move forward and reflect that stakeholder input. As I said, the other way to reduce the need for consumer assistance and streamline the whole process for everybody is to make website improvements, and we continue to do that, again, within the constraints of the resources we have available to us. But, some examples are being able to access now the state wage base so that we get better income information and fewer people who have to submit verifications. That's one example of the kinds of improvements that can expedite the process for everybody and reduce the manual work that needs to be done. We want to continue to work to create partnerships, to sustain ongoing partnerships, to help us with this outreach effort. Healthcare for All has been great, and we're working with them on their FAITH initiative, and I think that holds a lot of promise. You all may have heard about our bat phone pilot. I'm not sure who on the staff came up with that, but it stands for Broker Assistance Transfer Program. But anyway, that is an effort to engage brokers at the point in the eligibility and enrollment process where the consumer has been determined eligible by the call, been helped by the call center agent through the eligibility process, has been determined eligible for a qualified health plan, and then needs, the advice and assistance in choosing the best one for him or herself and their family. And so in part to reduce the volume in the call center. If we can reduce the average handle time of those of each call, then we can handle more calls. So we're piloting a program where at that point in the process, there'll be a warm transfer to brokers who have agreed to participate and sort of be at the ready, kind of in the queue, to take over these calls at that point. So we're hopeful that that will be helpful both to consumers, brokers, and the call center. You know, we're again, the connector entities have been great about working with other community resources in their areas, and as I said before, we're continuing to try to do website improvements to help us along. So what are we looking towards at this point? As I've said, more targeted outreach. With those maps I put up earlier, we're really trying to identify the areas where we want to, you know, target advertising, marketing, outreach, continued partnerships. We are, you know, you all have been leaders in recognizing the importance of consumer literacy, healthcare literacy, and the materials that we need to push out to both existing enrollees and new enrollees about how to use their insurance and how to access care. We're also trying to reach out to the business community with respect to SHOP to try to get more people into the SHOP program. We're developing the calendar of enrollment events. And this year, you know, we did in excess of 24 enrollment events last time. And I think they were really effective, both to enroll people at the events, but also sort of the media attention that we sort of put out there, created to drive people to the events. But in terms of, you know, sort of cost and effort per enrollment, they're you know, costly and a big effort. So we want to still have some, and as we said, we have about 12 and we'll probably plan a few more. But we're also going to use our marketing dollars to let consumers do a better job of letting consumers know about the stand-up walk-in places where they can enroll. And the connector entities have these storefronts now, and I think a lot of consumers don't know about those, and I think that will be an effective way to get people in for in-person assistance. Again, we're trying to use our marketing dollars as absolutely efficiently as we can, using the least expensive kinds of media to the extent that we can. How to enroll videos have been successful, social media, digital retargeting, trying to grow our fan base on social media, all those things. And we will continue our sort of real-time customer support through social media, which I think we were one of the, in part because of the problems with the website that first year. We did that more than maybe a lot of other states and have found it to be successful. As I said, trying to draw more attention to SHOP as that program gets more established, reaching out to the chambers of commerce, using LinkedIn more, and trying to make the website, again, we haven't been able to do, because of resources and time, to do like a real mobile app yet, but we tried to make it the website more mobile friendly. As more and more consumers, that's the way they, you know, access the internet, and it's through their phone, so we need to sort of stay up with the times in that regard. So in terms of what we're offering and what consumers are choosing, as you can see, there was some shift in market share between 2014 and 2015, and we expect there will be more. You know, as you know, the rates are out now, and there's a lot of movement, you know, up and down in the rates that I think will contribute to more of this market share shift. One of the things we've worked hard on all summer is auto renewal, so that the consumers will be able to be passively renewed into their current plan if they want to be, and that we are hoping will, of course, you know, ease the strain on all the resources through open enrollment. But we will at the same time be pushing out the message, as I'm sure all of you will too, you know, especially if there's been a rate increase in the plan you're in, come back and shop and see what else is out there. And this chart sort of shows you the shift in, the relative rates of the various carriers and what the cheapest plans are and have been and will be going forward. So we expect that that'll create some movement. This is just a timeline showing you the major events coming up. We're coordinating closely with the carriers to push out the letters telling people what their projected eligibility determinations will be, and then in November what the final eligibility determination is. Open enrollment, November 1st, everybody knows that one. So that, as I said, just gives you a sense. So quick summary of what we've achieved. Tens and thousands of people. 1 in 10 Marylanders are insured through Maryland Health Connection, either through Medicaid or qualified health plans. 9 out of every 10 people receiving financial assistance. So again, we're very proud of all that. I don't know what happened to the top line there, that's odd. But anyway, so in terms of challenges, one is understanding what's in the top line. But I think what that said was, Healthcare for All has done some focus groups and that just show what we all know, that kind of unbelievably, as we're in this room so steeped in this, we can't believe people don't understand these options available to them now, and can't believe people haven't heard about Maryland Health Connection and the new opportunities for health insurance coverage. But the truth is there's still large swaths of people who don't know about it at all, don't understand it fully, and understand that they qualify for for financial assistance, so they assume, they can't afford it. So we have still a lot of work to do there. As I said before, consumer health literacy, network adequacy. Where's Adrian? Is the head of our one of the co-chairs of our standing advisory committee. Has done a lot of work. Thank you, Adrian. And Lenny, too, has been on the work group. We're really trying to look at that to figure out what we can do vis-a-vis plan certification standards to help move the ball forward there, what we can do in working with other state agencies to get better data on network adequacy. And so we're not only working on that, but now as we're sort of hopefully moving into more of a steady state with the agency, we have more bandwidth to look at some of the important policy issues, network adequacy being a big one, but meaningful difference is another one. We have about 60 plans or so offered on Maryland Health Connection. Is that the right number? Is when you look at consumer choice and consumer decision making, is there enough meaningful difference in all of those plans that that's the right number to have? So those kinds of questions are important. The original enabling legislation allows Maryland Health Connection to begin looking at active purchasing in 2016. So that's another sort of big policy issue that we would like to tackle over the coming months. Still, of course, making it easier for consumers to enroll. We were hoping to get a really good cost utilization calculator this year, and just with time and resources, we're not able to do it. And we're hoping that sort of like computers get better every year and the iPhones get better every year, that by the time we can do it next year, the calculators will be that much better. But the last piece, of course, is the ongoing challenges of in-person assistance, of which you all are very, very familiar. So there we go. So that's all I have. I think we're saving questions for the end, right? Okay, great. Thank you.
So good morning. Happy Friday. Again, I'm Shannon McMahon. I'm the Deputy Secretary for Healthcare Financing. It's so rare that someone says they can't hear me. I just want to say first thank you to Carolyn again. A day does not go by where either Carolyn or John Crom, her deputy, or I are not talking. I know in the outside world it feels like government's operating in silos. A day does not go by where we're not talking, whether it's at 7 o'clock in the morning or 7 o'clock at night, texting furiously to try to smooth out little problems and smooth out big problems. So, we're great partners with one another, and it's been a pleasure, actually. I had the privilege of working very closely with them. I was actually on the Standing Advisory Committee for a while when I was at the Center for Healthcare Strategies and could be a bit of an outside cheerleader and occasionally a critic. And then, now got to step in this role where I had to put my money where my mouth is. So it's great to be here today. And let's see, how do I get my slides, Min? There we go. I do need to give a quick shout out to two people who are here, Sandy Kick and Laura Goodman from the Medicaid Planning Administration. They are the policy brains behind the operation, are just absolutely critical to our success in Medicaid, and frankly make me look good when I give presentations like this. So appreciate that they're here, and you guys staying all day. So they'll be here during the day after I disappear, and so if there are Medicaid questions that come up during the day, they're definitely positioned to answer them and help you out. So just a couple of quick things. I wanted to give everybody a little bit of a lay of the land because a lot has changed at DHMH since January. I came at the end of February and had done a tour at DHMH before, and I'm back again, and felt like it would be a good opportunity to do that, talk a little bit about Medicaid enrollment, and then in the back of my presentation, which is online, I understand from Ben, is a ton of really detailed information about the redetermination process, some of the IT fixes that Carolyn was talking about, resources where you can send folks. I see a number of the navigators represented here. Most of you know this stuff inside and out. But for those of you who aren't in that day-to-day or in and out of the day-to-day, in the back of my presentation, there's a good amount of information that I think could be helpful for that purpose. So in case you didn't know, DHMH is a really big place. It's a very big place. So we have a $12.4 billion budget. $10 billion of that is Medicaid. We have almost 10,000 employees, almost 3,000 of which work for the local health departments. There are 24 local health departments, including the Baltimore City Health Department that's, while technically independent. And then we have 24 boards and commissions. So that's the Dental Board and the Healthcare Commission and the HSCRC, as Lenny referenced earlier. So it's a very big place. It's a big job, and a lot happening. And to that end, when Secretary Mitchell came in January, one of the things that came to, I think, all of our collective attention at the executive level was that the mission and vision of DHMH hadn't been updated since the late 90s. So, in fact, when I went in and looked at the budget books shortly after the governor's budget was released, I realized that the mission of DHMH talked about how they were going to move the agency into the new millennium. So we were about almost 18 years behind. So it was time for a refresh and a time for us as an executive team to really talk about, what we saw as the future of DHMH. And so spent the day with all the deputy secretaries, our CFO, who we surreptitiously stole from Carolyn Allen-Pack, and our government affairs folks and our communications folks, and really got into a room together in Prince George's County with a minority-owned business, and started to really think about what our mission, vision, and values should be and what we should be, talking externally about. So we still have some work to do on some of the more granular measures, but we've all concurred on this. So the vision of DHMH is lifelong health and wellness for all Marylanders. Short, sweet, to the point, and a little bit more modern. And then I think our mission took a lot more work, but really wanted to kind of hone in on the fact that we work with everybody. We work together to improve the health and safety of all Marylanders through disease prevention, access to care, quality management. And that quality management, that's not just about the services we deliver, right? So measuring quality and on the healthcare side, that's where I go. But it's also about how we manage the agency, right? So it's about having quality people doing quality work, quality customer service, and community engagement, which is why I'm here today. So I think it's it says a lot. So I think go back, take a look at this, and think about it. It really says a lot about who we are, what we do. Again, it's a big place, but really tried to capture all of those things that the department does. The core responsibilities, obviously, we're the public health agency, the Behavioral Health Authority, run the Developmental Disabilities Program, and then, of course, Medicaid. And one of the things I think there's often
there's chatter in Annapolis, certainly back when I was a staffer in Annapolis almost 20 years ago, about DHMH being too big to fail. One of the things I will say that now that I kind of sit on the executive level there, the opportunity to coordinate and engage with one another with having public health and behavioral health and DDA in one agency is incredible. So just last week, the new Deputy Secretary for Public Health, Howard Haft, he's a physician, we looked at some data about C-sections and where C-sections happening out of control in Maryland, and sure enough, they are. We're above the mean in Maryland in terms of the number of C-sections. And what are our opportunities? What are the things we can do to, improve overall health for women, lower C-section rates, because we know C-sections aren't good. They're not a good consumer experience, and we know they're not good if they're not needed. And so trying to think about the payment mechanisms to fix that from a Medicaid side, from a quality measurement perspective, what the impact of that is on individuals' mental and physical health, and then from a public health perspective, what does that mean? And so I think it's a really interesting statement about how we can kind of tie those pieces together inside of one agency. This is just an new org chart at DHMH. Not a lot of changes, just a little more streamlined in terms of where the direct reports are to the secretary, 5 deputy secretaries, and then of course the regulatory programs that I mentioned earlier. One of the things, I'm not going to go into great detail about this, but one of the things that we decided to take on as an executive team is the CDC has had a series of winnable battles over the last 7 or 8 years, at the beginning of the Obama administration, sort of what are the things that we can tackle and solve over the next 4 to 8 years while Governor Hogan is here, and thinking about the ways that the agency can commit and focus resources on making measurable improvements. And so a number of these are, I would say, a little more public health focused. Sobriety and recovery, obviously a priority vis-a-vis the governor's interest in substance use disorder, the opioid crisis, but then also healthy lifestyles and disparities, very, very important issues for us in Medicaid. In addition to these, one of the things we're also working on are internal winnable battles. What are the kinds of things we can do for our employees, and can our employees do for themselves to make it a better place to go to work? I don't know how many of you have ever spent any time at 201 West Preston Street. It's not glamorous. It's not glamorous. It's a hard place to go to work every day, both from a location perspective, from a physical plant perspective. So what are the things we can do to make it a happier place to go to work? And some of that's engaging staff in exercises like this. Some of it's thinking about ways that we can do a better job of making it a healthy workplace, and allowing the employees a seat at the table to talk about that and to try to create some of those strategies. So it's a really exciting effort that we've just recently started over the last couple of weeks. Howard Haft, who I referenced earlier, the new Deputy Secretary for Public Health, is leading the external side of it. I'm leading the internal side of it, both from a customer service perspective and from the employee wellness perspective. So I wanted to share with everybody some of the policy priorities that we in Medicaid have over the next few months. So first, Carolyn really hit the nail on the head when she talked about consumer assistance. Consumer assistance is so critical for us to be successful on the enrollment side. So where's the right door, right? So we've got navigators who are doing a terrific job. I spent my day, actually half my day yesterday at HCAM, just frankly being another set of hands for them, where there's just enormous volumes of individuals who are about to lose their Medicaid coverage at the end of the month, and just trying to be there to be another set of hands, to understand what their business processes are, how we can be helpful, where the barriers are on the Medicaid side, where the IT challenges are, et cetera. And so trying to really hone in on where's the right door and where should we be directing resources to support individuals. I think I had this idea in my head that as long as people had access to a computer, that would be good enough, and I will say that it's not. It's 100% not good enough. Just based on the population we're serving and their needs, and the fact that this is kind of the first time they're ever having to do something like this, it was a really tremendous opportunity for me to see that firsthand, and to really hone in on where kind of our training opportunities are, and how we can think about who's doing what. Thinking about, again, what kind of consumer assistance people want, and where we should be directing the money. I think over time we'd love to see a model where the money follows the work, and that work is going to be directly linked to where people are going, right? So are people going to a navigator? Are people going to the local DSS office? Are people going to their local health department for assistance? Are they doing it online? Would they rather do it from a smartphone? So I think some of those questions that Carolyn raised are big ones and ones that we are really trying to tackle. For me, the other thing that's really interesting are the financial opportunities, and the opportunity for us to do a better job of care coordination for duals is really, really important. So folks who are dually eligible for Medicare and Medicaid, and I see Laura grinning ear to ear because we are very, very, very close to awarding a contract to start this work, to start consumer engagement, and to start laying the groundwork for a really robust project to engage with the HSCRC and think about a different way of delivering services and care and payment policy for individuals who are dually eligible for Medicare and Medicaid, and doing it in a way that aligns with the HSCRC project to leverage total cost of care. So a really, really exciting opportunity, and frankly something that I had been working on before I came to DHMH, so I'm glad to kind of be part of pushing it over the finish line. I am very, very passionate and interested in making better connections between jail, folks leaving jail and needing to get connected to Medicaid. And so we've done a lot of work from a business process perspective on the eligibility side and making sure people walk out of the door with a Medicaid card. But we also know that walking out of the door with a Medicaid card doesn't mean you have access to services or that you know where to go. And so we're really trying to puzzle through where some of those opportunities might be. Some of it has, for better or worse, been us having to say, you know what, a paper application is okay because Wi-Fi doesn't work in jail. But it's also that, you have an appointment to get your Vivitrol shot in 28 days. Let's make sure you get there so you don't, lapse and end up back in jail. And so we've really been spending a lot of time thinking about that in very close consultation with some of the navigators in the community, with our partners at the Department of Public Safety and Correctional Services. Very, very interesting opportunities there, and I feel I'm very passionate about it, and I'm hopeful that we can get a couple of things across the finish line. And then last but certainly not least, the hospital waiver. What are the things that we could do to benefit Medicaid from a financial perspective, from a care coordination perspective under the hospital waiver? The Duals project is but one of those. Readmissions, dental, for example, is another place where we could certainly leverage the hospital waiver to keep people out of the hospital and into care in the community if they have access to dental services. So for the last thing, I just wanted to quickly spin through, and Carolyn did a great job of it, but the ACA expansion has meant a huge enrollment increase in Medicaid. So we have almost 1.2 million members now in Medicaid. 1 million of them are in managed care. We have 8 MCOs where folks are served, and the vast majority of the Medicaid expansion folks enter directly into a managed care environment. And we have almost I think it's over 220,000 individuals are now enrolled in the Medicaid expansion. So next year is the first year where the state has to pay for the cost of care for the Medicaid expansion. We have to pay 5% of the cost of care. We are hopeful that money stays in the budget, and certainly welcome everyone's support for that. And then, of course, the enrollment on the qualified health plans. Carolyn did a great job of outlining that. This is a great, I think, visual depiction of where we were and where we are now in terms of Medicaid enrollment. I think most everybody's heard about the redeterminations. It's been a challenge, there's no question. It's been a resource challenge, it's been a timing challenge, it's been an IT challenge. I mean, in many ways, it's a byproduct of the first HICS, and now we're in the new HICS, and so we're really trying to work through it. There are a lot of folks who are up for redetermination for the first time, and we're losing people. And we are, along with DHR, doing everything we can to try to reach people. In fact, are texting people regularly, and our partners at DHR are going to be doing the same for folks who lost coverage. So not only reaching people who are about to lose coverage, but then trying to reach people who've lost coverage already. Hey, you know what? You lost your coverage, come back. Now is your chance. We can get you reconnected to an MCO. So really trying to, between the 3 agencies, partner very closely and come up with tools to get people back and get them re-enrolled. But Medicaid continues to grow. We've more than doubled our enrollment in 8 years. And I didn't put this slide in here, but I usually do. The number of staff in Medicaid while enrollment has doubled, the number of staff in Medicaid has changed by about, I think, 6 people over time. Yeah, it's incredible. And it's a challenge. It means that at times when we want to try to do things that are really interesting and innovative, we don't have the bandwidth. The staff don't have the bandwidth, and while they might have the energy, they just don't have the time. And so that's something that we're thinking a lot about. We are lucky that we have UMBC, the Hilltop Institute, who supports us from a policy perspective, from a data perspective. But that's not a substitute for people getting in and getting their hands dirty and being there and having colleagues to engage with and really helping advance that broader mission. So it's definitely something that weighs heavily on me and the leadership in Medicaid, and are hopeful that we can get a couple of additional hands over the next couple of years through the budget process. So I'm actually going to stop there. The redetermination information is all in here. For those of you who are kind of in the day-to-day of that, I think it would be helpful reference material, and I'm happy to answer any questions about that. And one thing that is in here is that redetermination schedule. So we're kind of in the peak right now. So to the extent you're on the ground, the more you can do to get folks in to get their redeterminations done, the better from our perspective. I know that it's incredibly busy at the local departments of social services, at the navigators, and so, as you're hearing things on the ground, share them with us. Tell us where the challenges are, where the difficulties are. My team on the eligibility side is incredibly responsive. We actually spent a day out with Uma and her team in Montgomery County, and are doing that across the state, just so that we can see what's working, what's not. Hey, in Montgomery County, they've got this great intake form. Can you take the intake form from Montgomery County and use it here in Baltimore City? So trying to convene and share some of those best practices is something we've been doing a lot of, too. So the more of that we can do, or that we hear from you, the better. So I'll stop there and say thank you for having me. It's great. I'm happy to do this anytime, and happy to answer any questions anybody has. Thanks.